Um, so for the later part of the morning, we're going to start with Brian Lee, who trained at UCSF and is now at USC. And he's going to talk about, Brian, is that you? Yeah, hi. He's going to talk about a early liver transplantation for alcohol-associated liver disease, a very timely topic. And so, Brian, take it away.
Hi, everyone. So I'd like to first thank the organizer of the meeting for inviting me to talk about this topic, early liver transplantation for alcohol-associated liver disease. So I have no disclosures. So for the overview of this lecture, we'll talk about the history and context of early liver transplant for severe alcohol-associated hepatitis, or ALCHEP, and also alcohol-associated liver disease, or ALD. Outcomes after early transplant in ALD, selection criteria, and future steps. So in the United States, rates and mortality from alcohol-associated liver disease, or ALD, have been increasing. ALD is projected to be the single most common cause of cirrhosis. It accounts for 48% of liver-related deaths in the United States and 50% worldwide. Alcohol-associated hepatitis, or ALCHEP, is a subset of ALD, where a patient presents acutely with jaundice from alcohol and accounts for 1% of US hospital admissions, which is a 26% increase in the last 8 years. Severe alcohol-associated hepatitis represents a subset of ALD. Compared to patients with ALD who present without ALCHEP, patients with ALCHEP are younger, and there's a higher proportion of women. Mortality is up to 70% at 6 months. While corticosteroids and N-acetylcysteine, or NAC, may improve 28-day survival, there's still no therapies that benefit long-term survival. Patients with severe alcohol-associated hepatitis are historically not eligible for transplant. This is largely due to the 6-month rule, which was an arbitrary suggestion in 1983 at an NIH consensus meeting for liver transplant, where a patient with ALD is required to have 6 months of abstinence from alcohol to be eligible for transplant. So when I was a resident at Johns Hopkins 8 years ago in 2013, there was a patient who started this entire research path for me. For this presentation, we'll call her Kate. Her history present illness, she was a 40-year-old white woman presented with jaundice and altered mental status. She was diagnosed clinically with ALCHEP. Her MELD score was 32, and she was treated with prednisolone, which was stopped at day 7 due to a allele score of 0.86. Her 6-month mortality was estimated to be 70%. She was transferred to Johns Hopkins for early liver transplant evaluation. Her past medical history included alcohol use disorder. Her exam, she was encephalopathic and overtly jaundiced. Her social history, she worked full-time at a desk job. She was a college graduate. She was single, and she lived with her parents, who were elderly in their 80s. They had a very close relationship. She had one brother who lived an hour away. She drank a 1/5 of vodka per day since she was a teenager, and her last drink was 1 week before hospitalization. She smoked 1 pack per day, and her brother thought that she lost a previous job due to quote-unquote abusing pills, but he wasn't so sure. She was listed for liver transplant on hospital day 13 and transplanted 6 days later. So at the time, I thought this was crazy. I knew about the 6-month rule and thought it made sense at the time. But does it really make sense? The fair question is, does it make sense in 2021? One of the initial thoughts was that the 6-month rule would allow time for the liver to recover with abstinence from alcohol, and a patient with severe ALCHEP might recover and not need an unnecessary transplant. However, we now know much more about the short-term disease course. We can predict with high accuracy who will recover and who will not with more sophisticated prognostic models, like the joint effect model, which combines MELD and allele scores. More importantly, the 6-month rule is unrealistic in severe ALCHEP. By definition, a patient with severe ALCHEP has recent alcohol use. But even though the presentation is acute, the disease is chronic, and over 90% of patients with severe ALCHEP have undiagnosed cirrhosis. Most quote-unquote survivors who present with severe ALCHEP retain an indication for transplant. A large prospective study from France illustrates this point very nicely. So more than 75% of deaths occurred in the first 2 months. the majority of survivors had a MELD of above 17 at 6 months. Only 15% were alive and without an indication for transplant at 6 months. And most importantly, short-term mortality is associated with the severity of inflammatory response, not return to alcohol use. So more recently, there's US data to inform the same question. The University of Wisconsin published their retrospective single-center study between 2012 and 2018. This included all 144 patients evaluated for early transplant with alcohol-associated liver disease, MELD greater than 25, alcohol use within 90 days of transplant. Not all patients had ALCEP, comprising 79% of the cohort. 34% underwent transplant, 66% did not. Only 7% not undergoing transplant achieved the quote-unquote compensated state, which was defined as a MELD below 15 and absence of medications for encephalopathy or ascites at 6 months. Patients with recovery, which was defined as survival without transplant, typically recovered within the first week of presentation. Younger age, less than 44, and lower peak MELD, less than 34, were most predictive of recovery with an accuracy of 82%. Probability of recovery was only 3% in patients with peak MELD above 34 and age above 44. Overall, liver transplant was the only predictor of long-term survival. So another thought was that abstinence before transplant could be a surrogate for a patient's ability to abstain from alcohol use after transplant. Since then, there have been a number of studies which show that the 6-month rule is an unreliable predictor of post-transplant relapse. More importantly, we now know that there are many predictors of alcohol relapse, so why should one, i.e. length of abstinence, have veto priority above all others? So in 2011, a Franco-Belgian group published their landmark study, challenging the norm. In a very select population of 26 patients with severe ALCEP, they performed liver transplant without a mandated sobriety period. The study showed a survival benefit. 6-month survival was 77% versus 23% with no transplant. 3 of the 26 patients, or 12%, had alcohol use after transplant, all more than 700 days post-transplant. So back to our patient, Kate. 72 days post-transplant, she presented with altered mental status, and she was found to be in alcohol withdrawal with a positive tox screen. She was quote-unquote bored at home and not accustomed to being unemployed. She was admitted 4 subsequent times with alcohol withdrawal and not willing to go to rehab. She was otherwise compliant with her immunosuppression, and 396 days post-transplant, she died from overdose after she was noted to be intoxicated at her father's funeral. So these experiences only offered a narrow glimpse into experiences with early transplant. To have informed debate on national policy, we needed to answer the following question: what is the broader US experience with early transplant for ALCEP? So we've formed a multi-center consortium to answer this very question, which includes 12 centers from 8 UNO centers performing early liver transplant for ALCEP. We've named ourselves the American Consortium of Early Liver Transplantation for Alcohol-Associated Hepatitis, or Accelerate AH. We published our initial results 3 years ago. It was a retrospective study of consecutive patients transplanted at each center for ALCEP. The study included 147 patients who underwent early transplant for ALCEP, meaning no required period of sobriety for transplant eligibility. The median period of abstinence pre-transplant was 55 days. It needs to be emphasized that these patients were very carefully selected. They had no prior diagnosis of chronic liver disease or prior episodes of ALCEP. They all also underwent rigorous evaluations by transplant social workers and addiction specialists. Regardless of the short duration of sobriety, the expectation remains of a commitment to lifelong abstinence after transplant. Investigators completed standardized data collection forms encompassing patient characteristics, drug and alcohol-related history profiles, medical management, explant histology, survival outcomes, and frequency and patterns of alcohol use post-transplant. So now for our results. This is a Kaplan-Meier survival curve. The y-axis represents the probability of survival, and the x-axis represents the time after transplant, up to 3 years. Our median follow-up at the time of publication was 1.6 years. Probability of 1 and 3 year survival were 94% and 84%. By comparison, with a median MELD of 39 and allele score of 0.82, the predicted 6-month mortality without transplant was above 80%. There were 18 deaths in total. 9 occurred within 90 days of transplant, of which 5 were due to sepsis. 8 of these 9 patients were early deaths and had received steroids pre-transplant for ALCAP. The remaining 9 deaths all occurred more than 1 year post-transplant. Of these 9, 7 were alcohol-related, 1 from alcohol overdose, and 6 from graft failure from recurrent alcoholic liver disease. We described alcohol use as any evidence of alcohol consumption post-transplant, regardless of quantity or frequency, which was largely based on clinical interview, liver biopsy, and ethylglucuronide or phosphatidylethanol testing, which was routine use at most Accelerate sites. Ethylglucuronide and phosphatidylethanol are metabolites of ethanol, and these assays can detect alcohol use in the past several days. So probability of alcohol use, any alcohol use at 1 year was 26%, and at 3 years, 33%. These rates were consistent with historic US cohorts for transplant and alcoholic cirrhosis with more than 6 months of abstinence. We sought to further define alcohol use. We differentiated between non-sustained and sustained alcohol use. Non-sustained was defined as a patient with evidence of alcohol consumption but had stopped drinking at last follow-up. Non-sustained alcohol use after transplant was not associated with significantly higher risk of overall death. Sustained alcohol use was defined as a patient who was still drinking at last follow-up. To differentiate between true sustained alcohol use and a recent slip, the minimum duration of alcohol use had to be at least 100 days. Sustained alcohol use was more rare, 10% at 1 year and 16% at 3 years post-transplant. Sustained alcohol use was the strongest predictor of death, associated with a 4.6-fold increased risk of death as compared to those without sustained alcohol use. So from this study, we learned that early transplant for ALCAP was being applied broadly across the United States. We found that early transplant and severe ALCAP achieved acceptable survival in the short term, but areas of concern were deaths related to infection and alcohol use post-transplant. So I've mentioned that ALCAP is just a small subset of ALD. The question often arises whether early transplant practices can be generalized to patients with ALD without ALCAP. There have been recent data published within the last couple months to inform this very question. So the first is from Johns Hopkins, which recently published an update from their early transplant program. This was a retrospective study of all transplant recipients for ALD at Hopkins between 2012 and 2020. The study cohort included 163 transplant recipients. 54% were transplanted early with less than 6 months of abstinence, and 46% were delayed with more than 6 months of abstinence. The median MELD score was 35 in the early transplant group versus 20 in the delayed transplant group. 26% of the early transplant group were without ALCAP. Outcomes were patient, allograft, alcohol relapse-free, and hazardous alcohol relapse-free survival. So here were their results. These are Kaplan-Meier curves up to 3 years post-transplant. In yellow, you have the early transplant group, and in blue, you have the delayed transplant group. On the left, there was no difference in patient survival. On the right, there was no difference in allograft survival. There was also no significant difference in alcohol relapse-free and hazardous relapse-free survival. The second study comes from my hometown, Toronto. So this was a prospective pilot study at Toronto General Hospital for early transplant and ALD between 2018 and 2020. It was funded by the Ontario Ministry of Health after a high-profile lawsuit started by the wife of a man who died from ALCAP after being denied early transplant with 6 weeks of abstinence. Their photo is at the top right. The pilot program was designed by a multidisciplinary panel of hepatologists, transplant surgeons, addiction psychiatrists, addiction specialists, ethicists, social workers, and hospital administrators. The selection criteria were similar to US experiences with notable exceptions. They included any ALD, including decompensated cirrhosis, HCC, and patients with multiple decompensation in the past. They excluded patients with hepatic encephalopathy as they found that their psychosocial risk was too challenging to evaluate, and also those with multiple failed rehab attempts in the past. They developed an integrated addiction program with a syllabus of topics over several sessions, which they called Integrated Relapse Prevention Therapy. All patients had post-transplant alcohol monitoring. So this is the flow of patients that went through their pilot program from referral to transplant. It's a busy figure, so I've summarized the key points on the right. So 703 patients with ALD were referred for early transplant evaluation. They were triaged by medical charts, supplemented by obtaining more information about their psychosocial situation remotely, so they were not seen in person. Patients were declined either based on their psychosocial or medical risk, and about 5% died while awaiting this triage step. 379 were formally discussed by the full transplant team. 101 were listed for early transplant, which represents 14% of all total referrals, and 27% of those who were formally discussed by the transplant selection committee. Among those who were declined, the severity of alcohol use disorder was the main reason in 84% of cases. The overall selection rate was higher than the original European experience, but similar to Accelerate, where 36% of those discussed were listed for transplant. As for the results, so they had 2-year survival as their primary outcome, and this was 89%. This was similar to post-transplant outcomes of patients with alcohol-associated liver disease and more than 6 months of abstinence transplanted at University of Toronto. Only 3 early transplant recipients had evidence of alcohol use post-transplant. 2 patients had slips and regained abstinence after engagement with addiction services, and 1 continues to drink and is non-adherent to medications. 2 of the 3 relapses were first detected through urine ethylglucuronide. The relapse rate was actually higher and more than double in patients with more than 6 months of abstinence before transplant, although the difference was not statistically significant. Younger age and lower MELD scores were associated with risk of alcohol relapse in the entire cohort. So to summarize the implications of the Hopkins and Toronto's experiences, early transplant can provide excellent intermediate outcomes in the broader ALD population, not only ALCEP. Alcohol use monitoring post-transplant with biomarkers and early interventions may prevent slips from becoming clinically relevant relapses, and that larger multi-center long-term outcomes are needed. So it was obvious from Accelerate data that early transplant was becoming widespread and increasing in its application. The Toronto and Hopkins data also show that centers have been generalizing their practices to not only ALCEP, but also to the broader and much larger ALD population. So we wondered, how were early transplant practices affecting the national transplant landscape? So modeling studies predict that NASH will become the most common indication for transplant. But more recently, ALD has become the most common indication for transplant. None of these modeling studies take into account early transplant practices, which are being applied beyond ALCEP and into the broader ALD population. So to investigate this, we published another UNO study looking at transplant recipients from 2002 to 2016. Many people assume that ALD had become the #1 indication for transplant because of the decline of hepatitis C. So for this study, we excluded transplant recipients with hepatitis C. The y-axis in this figure represents the proportion of liver transplants performed for ALD in the United States. The x-axis represents the year. Again, this study excluded hepatitis C. So with this study design, if the reason was hepatitis C decline alone, this graph would be totally flat, like so. But it wasn't. So you can see that there's been a significant rise in transplant for ALD, independent of trends with hepatitis C. So in this figure, the proportion of total transplants for ALD rose from 24% in 2002 to 37% in 2016. So we asked, could this rise be related to early transplant practices? Presumably, if centers were willing to transplant patients before 6 months of abstinence, there would be more eligible patients with ALD for transplant. So the red arrow coincides with the European report of early transplant for ALCEP at ASLD. The green arrow coincides with the first US reports at ASLD. We performed other analyses, included that ALD is now the #1 indication for transplant, in part due to early transplant practices being applied beyond just ALCEP and into the broader ALD population. On the right, we looked at regional increases of transplant for ALD. So there are 11 UNOS regions. The light bars represent the change in transplant for ALD in each region before 2011. The dark bars represent the change in transplant for ALD in each region after 2011. There are 2 important observations here. 1, the changes were very different across the 11 UNOS regions. 2, the changes in increase were not associated with secular or demographic changes seen before 2011. Rather, the regional increases were most associated with early transplant practices, meaning that transplant rates for ALD were rising unequally across the United States, at least in part due to centers deciding whether or not to adopt early transplant practices. Our findings showed that early transplant practices for ALD have changed the national landscape for liver transplantation. So early transplant practices for ALD have become particularly relevant during the COVID-19 pandemic, and I'll show you some data that we've been working on. So this was a study we published to assess the effect of the COVID-19 pandemic on retail alcohol sales. We use the Nielsen National Household Panel, which is a prospective longitudinal cohort encompassing over 70,000 households who record all their retail purchases, including e-commerce, by a handheld scanner or through their smartphone. The panel is nationally representative, is designed to be a mini USA, which allows weighted estimates of national sales. Our study period compared April 1st to June 30th, 2020 to the same period in 2019. This allowed washout of hoarding practices in March 2020, and the same period in each year controlled for seasonal variation in purchasing patterns. For our results, we found that national alcohol sales increased 34% from April to June 2020 compared to the same period in 2019. Alcohol sales increased in all demographic groups except in the less than 20,000 annual income group. The highest increases in alcohol sales were observed in higher income groups, which we hypothesized were due to higher disposable income, and among younger adults, larger households, and ethnic minorities, which are groups that have reported higher pandemic-related stressors. Since alcohol sales had been increasing before COVID, we calculated the predicted 2020 sales based on the 2017 to 2019 trends. And you can see represented by the gray bar in the figure on the top left, the red dot represents the actual sales, which was well above the predicted sales, making us conclude that the pandemic was independently associated with the rise in retail alcohol sales in the United States. So the question is whether the pandemic-related surge in alcohol sales has led to adverse health outcomes, and for our community in practice, whether this has led to increases in transplants for ALCEP and ALD. Before COVID-19, transplants for ALCEP were already surging, as represented on the figure on the left. The y-axis represents the number of waitlist registrations for ALCEP in the United States, and the x-axis represents the year. The red arrow represents the European New England Journal publication, and the green arrow represents our Accelerate Gastro publication. In 2018 and 2019 alone, there were more transplants for ALCEP performed than the 30 years prior combined. In 2020, ALD accounted for 40% of all waitlist additions and surpassed NASH and Hep C combined. Since the COVID-19 pandemic in March 2020 to February 2021, waitlist registration additions for ALCEP increased 325% compared to the 2018 to the 2019 trend. In January 2021, ALCEP accounted for 8% of total national transplants. Now, ALCEP is the fastest growing indication for transplant both in the United States and Europe. So given that there are an increasing number of centers performing early transplant, our consortium has tried to inform the community about the selection process. In other words, who is the appropriate candidate for early transplant? So this is a complicated question, but at its base, we can divide it into two broad categories. The first category is clinical criteria. We're looking for a patient who is at high risk of short-term mortality without transplant, who's too sick and unlikely to survive participation in formal alcohol rehab before transplant, and would derive significant survival benefit from an early transplant. The second category is psychosocial criteria. We're looking for a patient that, despite a short duration of sobriety, would be at low risk for alcohol relapse after transplant, and/or their alcohol use disorder is anticipated to be manageable post-transplant. And something I think is very important is that with the stigma associated with alcohol use disorders, there's need for objective and standardized criteria. Subjective criteria are vulnerable to bias and can cause inequity in access to early transplant. So to inform the first category, clinical criteria, we developed a model where we could virtually simulate patient outcomes in early transplant. So with the help of our collaborators at Mass General, led by Jack Chotwell, we developed a mathematical Markov-based model, which simulated 10,000 patients with severe ALCEP offered early versus delayed transplant, with varying levels of alcohol use pre and post-transplant. The bottom figure walks through our simulation model. So on the top is the early transplant arm. After a 17-day period to account for medical, psychosocial, financial evaluation for transplant eligibility, they enter the transplant waiting list, and then they undergo transplant. We modeled natural fluctuations in MELD, and at any time the patient could die. We used data extracted from UNOS, Accelerate, and other studies to inform all those likelihoods. The bottom is the delayed transplant arm, where a patient was under a 6-month probation period of mandatory abstinence before they could be listed for transplant. We found that offering early versus delayed transplant increased average survival time of patients a 4.49-fold increase in our base case analysis. The survival benefit of early transplant was maintained in all simulated extreme scenarios, including any estimated risk of sustained alcohol use after transplant. So this figure shows the net benefit of early transplant as compared to delayed transplant. On the y-axis, you have the allele score, and on the x-axis, you have the MELD score. We found that the survival benefit was highest represented by the yellow area for patients with MELD score of 32 or above, and allele score between 0.50 and 0.82. These are the patients who should be prioritized for early transplant. We also modeled scenarios where the mandatory abstinence period was 1 month and 3 months. We found that 64% of the survival benefit of early transplant is lost in the first 3 months. This emphasizes the importance of an early referral and an efficient early transplant evaluation. So to inform psychosocial criteria, we sought to develop risk algorithms to inform. We published a risk score to predict sustained alcohol use post-transplant, which we called the SALT score. The goal was to develop a tool that was based only on pre-transplant characteristics, so it could be used by selection committees. We used LASSO, least absolute shrinkage and selection operator, to produce a point score to predict sustained alcohol use after transplant. All demographic and clinical characteristics were evaluated in univariate analysis to determine whether they were associated with sustained alcohol use after transplant. This table represents the 4 variables that were significantly associated: multiple failed rehabilitation attempts, more than 10 drinks per day at presentation, history of alcohol-related legal issues like a DUI, and history of illicit substance use. The factors listed below were not associated with sustained alcohol use in our univariate analysis, including the high-risk alcohol relapse score. The high-risk alcohol relapse score was developed in 1993 in a cohort of inpatient male VA patients with alcohol use disorder. It's commonly used to predict alcohol relapse and alcohol use disorder after transplant. So our LASSO model then assigned coefficients to these 4 significant predictors, ranging 1 to 4 points per variable, ultimately to form the SALT score. So the figure on the left represents the proportion of patients with sustained alcohol use, stratified by low versus high SALT score. Amongst those with low SALT score, represented by the blue bar, 5% had sustained alcohol use after transplant. Amongst those with high SALT score, represented by the red bar, 25% had sustained alcohol use after transplant. So in other words, a low SALT score, 0 to 4, had a 95% negative predictive value, meaning 95% of patients with a SALT score between 0 and 4 were without sustained alcohol use after transplant. In contrast, the high SALT score, 5 to 11, had a 25% positive predictive value, meaning 25% of patients with a SALT score between 5 and 11 had a sustained alcohol use after transplant. At the maximum score of 11, the SALT score still only had a maximum positive predictive value of 50%. So the SALT score had a C-statistic of 0.76 to predict sustained alcohol use after transplant. In internal cross-validation across 10 random groups, the average C-statistic was 0.74, similar to the overall data estimate, suggesting the SALT score may be robust. This compares to the high-risk alcohol relapse score, which had a lower C-statistic of 0.56. The SALT score was recently externally validated by outside groups with similar C-statistics. So back to our patient, Kate. So how does our research data apply to her clinically? She had a MELD score of 32 and a allele score of 0.86. So based on our Markov model, early transplant was expected to provide 5 life years higher life expectancy as compared to delayed transplant. So it's a yes, she met clinical criteria for an early transplant. But what about psychosocial criteria? Here are the 4 variables incorporated into the SALT score. She met 2 of these variables, more than 10 drinks per day and history of illicit substance use. Her total SALT score was 5. So it's higher than the cutoff of 4, so she was not at low risk for sustained alcohol use post-transplant. But the positive predictive value of a SALT score of 5 is only 25%. So I would say that 25% positive predictive value is not very useful. And a low SALT score, which has high negative predictive value, helps to identify a good candidate for early transplant, but we still don't know what to do with a high SALT score. So we've been very interested in addressing these remaining knowledge gaps, not only to refine selection criteria, but also to inform post-transplant interventions and protocols. We now have longer-term 5-year post-transplant data with longitudinal repeated measurements. So our first project with the longer-term data was to identify discrete patterns of alcohol use after transplant with latent-class analysis and joint modeling. So there's currently no standard definition for alcohol relapse, and we hope to make concrete definitions on the patterns that we delineate to streamline future research. So these are accelerate patients, and this figure represents the patterns of alcohol use after transplant. On the y-axis, you have increasing levels of alcohol use, and on the x-axis, you have months after transplant. We identified 4 patterns of alcohol use: abstinence, late non-heavy use, early non-heavy use, and early heavy use. Abstinence accounted for 71% of patients. Late non-heavy use was 6%. Early non-heavy use was 15%, and early heavy use was 8%. This is a Kaplan-Meier curve demonstrating the probability of 5-year post-transplant survival by alcohol use pattern. So 5-year survival in patients with abstinence was 95%. Late non-heavy alcohol use after transplant did not affect 5-year survival and was 100%. On the other hand, 5-year survival was 62% for those with early non-heavy use and 53% for those with early heavy use. There was no effect of alcohol use on the first year post-transplant. It was 100% for all 4 patterns. We then simulated the probability of 20-year post-transplant survival by using our Markov model. For patterns 1 and 2, abstinence, and late non-heavy use, probability of 20-year survival was 72% and 74%. For our harmful patterns, early non-heavy and early heavy, probability of 20-year survival was 10% and 0.2%. We then evaluated all pre-transplant characteristics from their psychosocial evaluation to see if we could use them to predict different patterns of alcohol use after transplant. For pattern 2, late non-heavy use, any history of alcohol-related legal issues like a DUI had a trend. For pattern 3, early non-heavy use, history of multiple rehab attempts and overt encephalopathy were associated. And for pattern 4, early heavy alcohol use, younger age was the only significant predictor. So with more granular data, our ability to describe alcohol use after transplant and the impact on patient outcomes has evolved. About 80% of early transplant recipients have abstinence or late non-heavy use that do not affect 5-year survival. We identified 2 patterns of early onset alcohol use after transplant with more than 10-fold higher risk of 3-year and 5-year mortality, but not 1-year mortality. And this is unusual in the native liver. It typically takes decades of heavy alcohol use to develop cirrhosis. And in the transplant literature, alcohol relapse typically only affects 5 or 10-year post-transplant outcomes. So now back to our patient, Kate. Pre-transplant, in addition to a high SALT score, she had overt encephalopathy, which was a risk factor for early non-heavy use. And she was also young, which was a risk factor for early heavy use. Do we need to tailor the psychosocial and addiction evaluation to challenges unique to the patient population of severe LCAT? Patients who present with high acuity, younger age, and with a higher prevalence of encephalopathy. Post-transplant, she wouldn't engage in any abstinence program. How do you enforce addiction treatment? And what interventions are most effective when transplant is already performed? These are the questions that still remain. So the field has come a long way now, and these have been evidenced by changes to national policies and guidelines based on these data. So the American College of Gastroenterologists released new guidelines in 2018. The decision on transplant evaluation should not be based solely on minimum 6 months of alcohol abstinence, and other criteria should be taken into consideration. Patients too sick to complete rehab therapy may be considered for transplant by exception pathway dependent on individual center policy and the patient's profile. The ASLD released new guidelines in 2019. Transplant may be considered in carefully selected patients with favorable psychosocial profiles in severe LCAP not responding to medical therapy. And in 2020, the American Society of Transplantation released consensus guidelines. An inflexible period of abstinence prior to transplant is not desirable. Acceptance of transplant listing should be based on the severity of liver dysfunction and a comprehensive psychosocial evaluation. So to wrap up, I'll leave this summary key slide, which summarizes the data that I've presented to answer a very common question. When do you refer a patient for early transplant in ALD? The 6-month period of abstinence is no longer a strict requirement for liver transplant. So I would say if a patient meets clinical criteria, i.e. a allele score of more than 0.45 if severe LCAP, or MELD above 25 if decompensated ALD, and they have lack of any other serious comorbidities, and they meet psychosocial criteria, i.e. first decompensation of liver disease, meaning no alcohol use after a diagnosis of ALCAP and or cirrhosis, a strong commitment to lifelong abstinence, and strong social support. These are the patients who should be referred early for transplant, and it's important to refer them as early as possible. And just to go on a little bit of a tangent, based off of the panel discussion, I have a little bit of a different take on that. I think that the first research population is really ALCAP, but the research field has evolved past that to really address real-world questions. And I think that the real-world clinical question is, when someone has life-threatening liver disease with recent alcohol use, and they need a decision about transplant versus not, how do you make that decision? So for example, say a patient who comes in, and this is a real patient that we've seen recently, a 40-year-old woman who comes in drinking 2 to 3 glasses of wine. She's ruled out for every liver disease, and she has a MELD score of 40. Do we care whether she has ALCAP or not? Do we care about other things? For me, the first question is, do I think she'll recover from this life-threatening liver disease? And then 2 is, do I think she can be committed to lifelong abstinence after transplant? I think those are the practical questions, and I think those are the questions that should be reflected in transplant center policies. So in conclusion, alcohol-associated liver disease and ALCAP are on the rise. Early transplant for ALCAP appears to have acceptable outcomes with careful patient selection. Further study is necessary to improve outcomes and to inform national policy. Early transplant is being applied to the broader ALD population, not just ALCAP. And finally, interventions and further research is needed to improve selection and to prevent and treat alcohol use post-transplant. So I'd like to acknowledge all of our collaborators. This has really been a long and fun journey, but it's really required a lot of effort and a lot of collaboration. So all these listed on the slide really contributed significantly to the data that I presented. Thank you for your attention.